Hey y'all, so there's no assigned reading for this week, but I do want to look at some CT protocol fundamentals for us. These will be important for each and every protocol that we consider throughout the course of this class. So there's just some general concepts. They're found in chapters 10 and 11 in our textbook. And we're also going to be looking at some other kind of required sources for this class, specifically the ARRT material. First off, I've got some learning objectives for us. I want to talk about the basic do's and don'ts of communicating with the patient. That's pretty much my summation of chapter 10. And then for chapter 11, we're going to look a little bit deeper. We'll talk about how to prepare the exam room, getting patient medical history, why we ask the questions that we ask, and then how to assess for the patient. Some of this will be kind of a review of patient care type stuff. Then we'll look at ARRT information, and I'll real briefly look at the American College of Radiology's contrast manual. We'll be looking at that more in depth in about 2 or 3 weeks. So first off, let's talk about what communication is, why it's important. Communication is going to be a major tool that we'll use for making sure that our patients are safe. It's also going to be the way that we make sure the patient tracks with us, that they trust us. Kind of the fancy managerial term for that is retention, that the patient is going to take this ride with us and that they feel like they're in competent hands. Of course, all of that streams into money streams like referrals and malpractice and blah, 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 blah. Additionally, the way that you communicate, the way that you treat people is going to impact your own sense of job satisfaction, your overall morale, as well as improved efficiency. It may seem like communicating can increase your time, but actually it can wind up making things move quicker, more consistently. You may be able to speed things along by practicing poor communication in the short run, but ultimately it will catch up with you in a big way. So some habits to avoid. False reassurances are a big one. So don't tell people it's going to be okay. Don't tell them to have a nice day. You know, don't tell them that something's going to hurt, not going to hurt if it is going to hurt. Do your best to give your patient choices as much as possible. You know, do you want a pillow? Yes or no? Do you want a pillow underneath your knees? Would you like a blanket? When at all possible, give them a choice. Don't assume that if a patient's unresponsive that they can't hear you. They probably can. Be really mindful of the kinds of conversations that you're having within earshot of a patient. I've been a patient myself in the past, and you know, technologists or nurses or whoever were joking, and it felt really weird that I'm sitting here hurting and they're sitting there laughing. I know that they weren't laughing at me, but I can imagine if I was even in a slightly more compromised state, how offensive that would have become. It's important that we don't blame the patient for anything at all. They're already having like the worst day of their life, so don't heap stuff on top of them and avoid any kind of medical lingo. And the same is true for working with patients' family members and stuff like that. So things that we want to do is be good listeners, use focus questions, and questions can help us refocus if we've got a patient who is really chatty or is giving us all sorts of history that may not be true. You know who I'm talking about, those patients that are poor historians. Asking questions to redirect the conversation is a really effective way of interrupting them that doesn't feel like interrupting. Like I'm still engaged with you if I'm asking a question. I can think of one person who maybe got upset because I kept asking them questions, but there was some other stuff going on there as well. And they were having a real hard time focusing on what was being said and what they were saying. There are appropriate times to use touch, so use your discretion on that one. But I think in particular about when we're moving patients in and out of the CT gantry, that may be a time to place a reassuring hand on the patient's shoulder. Make sure that you tell them what you're doing before you do it. I'm going to move you into the gantry now, and place the hand on their shoulder as a way to assure them that, you know, I told you this was going to happen, now it's happening. That kind of thing. It may seem like a no-brainer, but if it's their first time doing something like that, that's a big deal. And then give them as many opportunities as possible to ask questions. And you may have to like pause and wait before the person asks or thinks of their question. Don't assume that just because someone is quiet that they're not thinking. That's preposterous. A lot of times thinking requires some silence, right? So ask the question, pause, and wait for a response. And then once they do respond, reflective speech just means, so I heard you say that you were hurting in your right lower quadrant. Is that correct? Yes, that's correct. Because sometimes people may be compromised. They may have forgotten their right from their left. Can you indicate where you're hurting? Those types of things. I see that you've pointed to your right lower quadrant. Is that where you're hurting? So being consistent, being repetitious. As many times as I repeated things that patients said to me, I never once had a patient say, why are you repeating everything back to me, right? It's just like if I was at McDonald's or someplace and I ordered some food, I would want them to read that order back to me. Because sometimes I wonder, can I trust them to take my order right, or maybe the intercom's not working, whatever. How much more important is it for us to read stuff back to people in the healthcare setting where it's not just like hamburgers, but it's like their life that's on the line? So changing gears just a little bit now, we're going to talk about chapter 11 in the textbook and how they've got some general outlines of how to select protocols for patient care in CT. So this is ultimately the responsibility of the radiologist. So we're working in a team with the radiologist, and we're going to need to communicate with them really closely. That may be different from some of the other expectations that you've had. Like if you're in radiation therapy, you'd be like, what? Work with the radiologist? I've never worked with the radiologist. Yeah, I get it. In fact, I mean, historically, like when my dad was in medical school, radiation oncology and radiology were still in the same department. They only broke out like in the, I think it was in the 1970s that they kind of split out and became two different departments. But yeah, if you're working in diagnostic imaging, you want to make sure that you're communicating with the radiologist about any questions about the protocol, communicating with the requesting physician. For therapists, you know, if you're doing a CT simulation, I would always have the oncologist check in on what I had simmed prior to doing the CT scan. So similar kind of concept. I'm sure the same is true for nuclear med. Y'all probably check in with radiologists if you have any questions about the protocol that's been ordered or whatever before initiating the protocol. So make sure that you've done your homework, though, before you check in with the physician. You want to get as much patient information as you can, particularly stuff related to their vital signs, clinical history, age, gender, et cetera, those types of things. Because really what we're trying to ask is this the right protocol for them, and what risks are associated with this protocol? At some places, the radiologists review every single CT that you do prior to doing it. At other places, it's like the admin out front is the one making sure you're doing the right thing. I've seen both facilities. I've seen pros and cons to both. So at the end of the day, in reality, it's really up to our best judgment to negotiate within the protocols of the procedure, the policies of the location that we're at. Couldn't get that out. All right, room preparation. These are all kind of no-brainers, but you want to warm up the scanner before anyone's in the room, right? Because there's radiation when you warm up a CT scanner. Make sure it's clean, because that is really like the first impression that the patient has of the department is when you wheel them into the exam room, and if there's like blood stalactites from the ceiling tiles, you're probably gonna have a problem. In the same way, and I hate ironing my scrubs. The little thing that I do is I would always spritz my scrubs with water and throw them in the dryer, and then immediately put them on, and they look like they were ironed or pretty close to being ironed. Maybe not ironed that morning, but ironed recently. It worked for me, and you know, remaining clean cut, those types of things. Anything you can do to make to look clean, right? Because that's, you know, what people want. They want healthcare in a clean environment. Also, in addition to that, the CT scanner is going to work better if the room is clean. It can, like if the room gets dirty, it can literally throw off all sorts of calculations within the CT scanner. You know, just like if you dropped your cell phone into a mud puddle, you'd want to clean it up. You know, basically every single patient that you do in the CT room, you're dropping the scanner into a mud puddle. So clean it up. Make sure that the equipment's prepped and ready to go for the patient. Everything's ready, like in terms of emesis bags and washcloths and anything, suction canisters, IV supplies. It can get freaky pretty quick. All right. So once we've got the patient sat down in the exam room, that's generally the best place to get medical history, or somewhere close by the exam room. And we got 3 goals in seeking this history. The first is to make sure the patient's going to be safe during the exam, particularly if we're using IV contrast, make sure that the right exam is chosen. So in communicating with the radiologist, making sure that we're doing the right thing for the right diagnostic criteria. And then finally, ultimately, to have that history to communicate to the interpreting physician so that they can understand why they're looking at the pictures that they're looking at, because we're going to give them a crap load of pictures. And if you're looking at like 1,000 pictures and you have no clue why you're looking at it, that could be pretty frustrating. And make sure you verify the patient's ID. So all the patient safety questions that we have are twofold. First is making sure that they're not pregnant, so we'll ask of last known menstrual period, and we'll kind of calculate from there, right? Ideally, we would do the scan within 10 days of the last known menstrual period, because that's kind of a make it or break it time for a child. If the patient had conceived, it's kind of an all or nothing thing during those first 10 days of pre-implantation, and we'll talk more about that in radiation biology. But last known menstrual period is helpful for us. Or, are you pregnant? Is there a chance you could be pregnant? Are you been trying to get pregnant? Those types of questions, it's like, hi, my name is Ben. Any chance you're trying to get pregnant? Yeah, figure out ways to kind of break the ice a little bit, but they should understand why you're asking, and it has to do with radiation. And then the other huge concerns that we are interested in, probably the bigger issue in some ways, is safe use of IV contrast, because stuff can get crazy real quick. We're going to spend a whole week on that. All right. Now, in terms of examination protocol selection, you will see all sorts of wackadoodle stuff come across your table asking you to do a scan of whatever for whatever reason. Just because you got a patient and a doctor's order doesn't mean that they know jack doodly about what it is you do, to be quite honest. We are really on the cutting edge of medical technology, and a lot of times people do not know very much about what it is we do. And that makes sense, because you've had 2 trimesters of it, they've had 0 trimesters of it. So really step into the role of an educator to some degree and work alongside the radiologist to make sure that you're doing the right thing. Also, you're going to have to put on your detective hat a little bit and do a little CSI work to figure out, well, why are we doing this? Like, why are we doing this? It might make sense, but keep kind of an open mind and get history relevant to the exam that you're being asked to perform, right? Like if you're doing it, if they've requested a CT of the abdomen and pelvis, the patient states they have a headache, it's difficult to see how that might be of use. So also knowing, acute versus chronic, whether this is getting worse, those types of things are helpful. And any previous exams done at other locations, even helpful to know. Diagnostic information. So these are things that might show up on the CT scan, like if they've had their gallbladder out, previous surgeries, other medical issues like diabetes mellitus, cancer diagnosis, pretty much anything that could alter the normal state of anatomy I need to know about prior to starting a CT scan, as well as any current symptoms and stuff that we might be looking at. Lab values are important to us, and you want to be good friends with your lab department. I am the weirdo who will buy Christmas presents for my lab tech because I want those lab results quickly, because sometimes labs are the one thing holding me up from getting my exam done. So the main things that I am interested in are serum creatinine. That's not creatine. This isn't like the weightlifter stuff. It's creatinine, which is basically, I don't know a nice way to put this, but imagine that there's PP floating around in your bloodstream. That is creatinine. And if there's a lot of PP floating around in your bloodstream, I don't know why I'm using that word. I've been surrounded by kids for too long. If there's a lot of urine in your bloodstream where there shouldn't be urine, we can assume that your kidneys are not functioning very good, right? And we want your kidneys to be functioning good because we're going to give you this weird contrast stuff that's going to make your kidneys work that much harder to get this weird contrast stuff out of your bloodstream. That's what the serum creatinine tells us. It tells us kidney function relative to the amount of urine in your bloodstream. Yeah, hopefully you remember that. And that is reflected in the serum creatinine. Normal creatinine levels are 0.5, 0.6 to 1.7. Most facilities, though, at like 1 or 1.2, they start questioning the amount of contrast that should be given to the patient. So continue to communicate with your doctor, familiarize yourself with your facility's normal limits for creatinine. The higher it gets, the worse their kidney function is. That's how creatinine works. eGFR, just for complexity reasons, works the complete opposite. So the higher it is, the better your kidneys function. So eGFR is based off of your creatinine plus the patient's age, gender, and some other stuff like ethnicity. So for example, say you've got two different patients, one of them who's African American and the other one is Caucasian. The African American will automatically have a lower eGFR. And that's just kind of the brute realities of kidney function type stuff. We'll be looking more at that when we get into talking about IV contrast. But the eGFR takes into consideration some additional criteria for evaluating kidney function. And it is the opposite. So if it's low, kidney function is poor. If it's high, kidney function is good. Confusing enough. The final thing that we might look at is if we're doing any kind of procedure, and by procedure I mean something where we're sticking anything into someone's body, right? That could be a bleeding point. So not necessarily a enema, but if we're cutting people or placing drains inside of people, we need to know what their clotting factors are. So any interventional CT procedures, I worked in interventional for about 2 years. We always would try to get a PT, PTT, and other measures like a platelet count to see what their clotting factors are. So we PT, we want basically it to turn around pretty quickly. Same with PTT. If we start to see that longer, the patient's on some kind of blood thinners or something, it means if you cut them, they're going to keep on bleeding, and that's a problem, as you can imagine. So finally, we are working, as I've mentioned previously in this lecture, as educators. We're going to be educating our patient about how the procedure works, how long it's going to take, whether or not we're going to be using IV contrast, and a little bit about what IV contrast is, and what's expected of the patient. Now, the reality is, right, when we're talking about these CT protocols, there's a lot of stuff in the CT scan room that can kill a fool, right? Straight up. A lot of things that can kill a fool in the CT scan room, right? I'll tell you, like the tech told me when I was first learning CT. She pointed at the CT scan table and she said, there'll be no births, deaths, or conceptions on this table, right? And probably the one she was most concerned with was the deaths one, right? Because for real, the IV contrast injector can kill you, the CT scanner can kill you, negligent techs can kill you, the IV itself can kill you, the contrast itself can kill you, the IV can kill you if you're doing any kind of procedure, that can kill you. So there's a lot of risks, you know, related to radiation and et cetera, et cetera. You don't need to tell the patient that, but you do need to educate them on the fact that you need their cooperation, that they're part of a team with you and getting the procedure done effectively, and making sure that you reduce any anxieties that they may have. In terms of avoiding killing them, that's why you get paid the big bucks. You need to get some basic consent from the patient, even though they've probably signed consent for treatment prior to entering the facility. You need just like basic agreement with the patient that like you explain to them that you're doing a CT scan, they're cool with that, right? We're going to call that written or informed consent. Particularly if it's of a more invasive nature. So again, CT procedures, the doc's going to need to do it. If you're doing a CT with an IV in it, then you can just let them know, hey, I'm doing a CT, and they'll sign off saying, yeah, he did a CT. There may be some things and ways that we want to keep the patient immobilized. This is different from restraint, right? So those words, I'm choosing them carefully. Patient immobilization is stuff to help the patient hold still. It's not going to force the patient to hold still. That's a restraint. But stuff like a head holder is patient immobilization. Even a knee sponge is a form of patient immobilization. The way that the couch is designed is a form of patient immobilization. Some CT techs choose to put like straps over the patient's belly or whatever. Immobilization, not restraint. It's just Velcro. They could tear it off if they want to, and they will. Assessment. We're constantly assessing people, right? I always imagine I'm kind of like the guy at 7-Eleven or wherever, looking at the height for each person that walks through the door. But I'm not necessarily trying to size them up for criminal activity. I'm trying to size them up for how likely they are to croak in my exam room, right? So I am interested in their ethnicity. I am interested in their age. I am interested in their gender. All of those things are factors. I'm interested in their level of anxiety, right? All those things can influence just how successful they will be in getting the CT done in a way that's happy for everybody. So visual and verbal contact is going to be important. I'm going to be real chatty with them. Like, hey, how you doing? You doing okay? I had one guy who was like, hey, stop asking me that. You keep asking me like 50 times if I'm doing okay. Well, it's because you're sitting there breathing weird, you know? Stop breathing like that. Well, I mean, keep breathing, but not like that. All right, vital signs. These are going to be super helpful for us, and I don't know why more techs don't like get real religious about this. I'm super on top of all this stuff. I document all this. This is helpful to me. What is the body temperature, the most recent temperature? You can get it out of the E-chart, right? We know what normal is. Pulse. It's helpful to know a pulse as well, especially if they're on like some kind of pulse oximeter device or whatever. Go ahead and write it down. Like, how hard is that? You know what normal is. You know how anxious they are. It's helpful to know, right? And we'll talk more about why that's the case, but particularly when you're giving contrast, there's like a kind of anxiety attack that people can have when you give them contrast that looks a lot like a contrast reaction. It's not. It's just a freaking anxiety attack, but it involves projectile vomiting and all sorts of crazy stuff that, like from the movie The Exorcist type stuff, and it's just an anxiety attack, right? But pulse would be a first sign that the person's anxious. Also, biofeedback is for real. If you point out to a patient that their pulse is kind of high and ask them to work to lower their pulse, they can. That by focusing on a vitals monitor, you can lower your own pulse. Biofeedback. All sorts of research validated. Here's the normal ranges. Respirations, you can count respirations pretty easily. And again, these are super helpful to have if the patient's having a contrast reaction. It's helpful to have what their normal respirations were prior to the contrast reaction. That's super helpful. Once they're having the contrast reaction, if you don't have the normal stuff, you're kind of up a creek. So do it before you administer contrast. Finally, blood pressure. I routinely check blood pressure before I do any CT scans. I think people are crazy not to. And I know that people commonly don't. I worked at a lot of facilities where they thought I was crazy for doing a blood pressure until I started noticing that a lot of patients had really high blood pressures, and then they questioned, why are we doing a CT scan? We need to do something else. So it is a vital part of the history, and again, it will help us out very much if the patient has a contrast reaction. So all this stuff is kind of foundation. If you're noticing a theme here, right, there's a reason why we're going to be talking about that in about 3 weeks. Normal, though, is about 120/80. That's a little high for me, but whatever. All right, let's toggle over to the ARRT now. Yeah, ARRT time. So you're going to want to search. You can get to your own search machine, right? However you search. Do people still search off of things other than Google? I mean, that'd be a weird individual, right? We'll jump into a search machine. You're going to put in ARRT content specifications, search that out first off. And the ones that we're interested in, you can click on this link here. It'll take you to the landing page here. And this is a really interesting document. I just want to point it out to you because it is a required document for this class. And what it's going to do is it's going to give you all that's on the actual CT registry. Computed tomography for the ART. Now, some of us might be thinking at this point, I don't need to know what's on the ART registry. I need to know what's on the whatever registry, right? Well, check yourself before you wreck yourself, yo, because really the only thing that's recognized nationwide in terms of CT certification is the ART registry. So even if you are registered in some other modality by some other registering body, chances are I'm about 99% certain you're going to want to take the ART CT registry, and this document's going to be your best friend at that point because it tells you what's on the freaking exam. And you can see here we're going to be using a lot of this information to guide our learning in this class. So this has a really good outline of how protocols work. And if we scroll really far down, here's the actual protocols we're going to be looking at and thinking about all these things over here. The other thing that we want to look at is the ART task inventory. This is similar. And the same is true there's a task inventory for radiography. There's a task, they really bury these things, by the way. That's why I'm Googling it. But the ART task inventory for computed tomography, it looks similar to it, but literally, this is the exam. This is a standardized test, right? And part of a standardized test is they have to be real specific on what they test. So, little nugget there for you. This is the exam. If you scroll through this tells you exactly what's on the test, right? In fact, it probably has exactly, it has close to the same amount. I'll show you a way to kind of figure out like how many of these particular questions there are on any given exam, but you're going to be tested on each one of these items if you take the registry exam, and so we will be looking at each one of these items through the course of this class. The final little thing that I think will be helpful for us to search out here is just the American College of Radiology Contrast Manual, ACR Contrast Manual. So you click Google that, and here's this bad boy. Again, I think it's best to Google it. This one they're good about, they kind of keep it front and center on their website, but it gets updated from time to time. In fact, I have not yet read this version, so yay, I get to reread the manual on contrast media. You'll see why I'm so excited about that in a few weeks. This one's yeah. But it is exhaustive. There actually are some pretty interesting parts to it. It's going to have a lot more information in it than we need because it deals with other forms of contrast besides iodinated contrast media. Like it looks at gastrographin and some other stuff. But yeah. So hopefully this was helpful. I miss seeing y'all face to face, but this is the new normal, as they say. All right, bye.